Hi, good morning, everyone. Welcome to another awareness talk from Mind Story. So before I start, let me briefly introduce myself and Mind Story. Okay, my name is Charlie. I'm a registered counselor for Mind Story. Okay, here in Mind Story, we provide services for children that have academic delays, sensory delays, developmental delays, behavioral and emotional difficulties, as well as physical delays. So in Mind Story, we have a team of professional from different discipline or background. We have academic support, which is special needs teacher or special education teacher. We have behavior therapist, a clinical psychologist, counselor, occupational therapist, reading therapist, as well as physiotherapy. Okay, you can contact us or email us, and our operating hours is from Monday to Friday, 8 a.m. to 5 p.m. We are open on Saturday and Sunday as well. We are via private appointment only. So those parents or who join us every month, if you have any topic that you want us to cover for our talk, feel free to email us, or if you have any inquiries, you can just WhatsApp us. Okay, you can check us out at Facebook at mindstory.my, our Facebook page. We will upload at the beginning of the month about the upcoming talks or any short courses or workshop available from Mind Story. You can check out our website at mindstory.com.my, Instagram mindstory.my, and also LinkedIn Mind Story and bracket Pusat Latihan Kanak-Kanak Berkepuan Khas. Okay, so today we're going to talk about child development. So for those who did join us from the previous workshop, I do share about different types of diagnoses and also the importance of diagnosis and also who can do it. So recently, we have last month, I have parents who have concern about where to go, what to do. Okay, so on the last talk, I did share about the importance of finding the right person. Okay, so today I'm very much going to focus about one type of the health professionals that can provide diagnosis as well as give us the direction or provide parents with a direction like recommendation what to do after seeing the doctor. So basically, we are looking at a doctor. Okay, so like I have shared before, there are different types of doctors, and people are wondering what to do. Okay, where to go. And then also like what type of doctors I have parents asking me, what type of doctor is the appropriate doctor, okay, and which type of doctor can do diagnosis, which type of uh, 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 specialist they should go to, okay, and then also what should they do, when they see a doctor, okay, what should they ask or what should they do? Okay, so this is very important when it comes to planning. Okay, I mentioned before in the previous uh, talk, planning is very important for parents so they can know what can they do for the child when it comes to development. Okay, and where should they go? Because nowadays a lot of services are available in Malaysia. Okay, not only overseas. Okay, so let's start with who do you look for. Okay, this is a very general. This is based on my opinions and also parents' opinion. But it's up to the parents. Parents have choices to make. Okay, one of the thing is uh, government hospital or private hospital. Okay, for me, from what my experience working with parents, either way will do. It depending on what you're looking for and your budget. Okay, obviously, government hospital will be cheaper as compared to private hospital because government hospital doctors inside the government hospital they are heavily subsidized by the government. So seeing a specialist in a government hospital only costs you 5 ringgit as compared to private. Okay, so that's the difference. And then also we talk about medical doctors. Okay, normally, okay, if your child is no longer having a review with a pediatrician, you can go to a GP and ask about, like if you suspect there's something wrong about your child, you can share it to the doctors. Okay, so if your child is currently have a review or monthly review or yearly review with a pediatrician, you can raise your concern as well. Okay, like let's say your child has, you notice that your child uh, language or speech is slightly slower than other kids of the same age, or in a kindergarten or in a preschool, where the teacher feedback, okay, they'll share with the parents. I think your child has talked slightly less, or unable to make a full, express in full sentence. Let's say a child is 3 or 4 years old, okay, and then still babbling. So these are some of the things that you can bring up to the pediatrician. Okay, so today in particular, we're going to talk about medical doctors, because we have our invited guest here. I'll introduce her later. She's going to share with us about her role and also the red flag for child's development. Okay, so government hospital, private hospital, when you go and see a doctor, their standard of procedure is almost the same. Okay, doctors practice the same way in Malaysia. Okay, so what I normally suggest parents, first thing, if you not sure where to go, always approach a GP first. Okay, or clinic kesihatan. If you talk about government hospital, we have clinic kesihatan, and you can look for the doctors there, GP, or they call it medical officer. Okay, and then screen. They will provide like screening. They'll ask you questions. You can also share with the doctors your concern, and also the feedback from the school or any way of your observation. Okay, from there, then the GP or the medical officer from the government side, they will refer you to a specialist or to the nearest hospital. Let's say if you go for the clinic kesihatan, normally the procedure, they will write you a referral letter to the nearest hospital. Let's say here in Subang Jaya, you go to clinic kesihatan here, around Subang Jaya, they will refer you to Hospital Shah Alam. Okay, and then from Hospital Shah Alam, there is a pediatrician, okay, and then they will do a screening. So it's not only pediatrician, in government, they have a rehabilitation team where they will screen for your child's development. So in terms of your fine motor skill, gross motor skill, okay, cognitive, communication and language skills. Okay, so these are done by different types of health professionals. Okay, and then from pediatrician, let's say you would like to go for a more specialized area. Okay, that's where you can see like developmental pediatrician. You can see like a child adolescent psychiatrist. Okay, so the process, that's the general process when you see a doctor in government hospital. Okay, so let's say in private, you can also do the same. You can normally you go for a pediatrician, and the pediatrician suspect that your child might need more assessment, which is not in their area. That's where they will also refer you to a developmental pediatrician. So then you know that you're looking for a person in terms of based on what the pediatrician has recommended or suggested. Okay, so this is the important things for every parents or even teachers or anyone out there. So like here in Mind Story, I myself emphasize a lot on seeing a doctor first, because after diagnosis, normally the doctor will suggest to you what to do next. And then that's the most important part, in my opinion. Okay, so you have your diagnosis, if your child really have difficulty or learning difficulty or, autism or ADHD. But after that, it's something that is very important, because the doctor will let you know based on certain area affected because of autism or ADHD or any other difficulty, then certain therapy is needed for this area. Okay, so intervention planning. Okay, by going to doctors, all the doctors practice standardized across Malaysia. So, and then once when they refer you to see a developmental pediatrician, Okay, this type of pediatrician is the number is not many. Okay, I would say it's about 11 or 12 around Malaysia. The whole Malaysia, I think there's about 11 or 12 of them only. Okay, so be it a government hospital or private hospital, the waiting list, there will be a waiting list. Some will be a year to 2 years. Okay, so the only difference is the price, but the waiting list is there. Okay, so developmental pediatrician is a very specialized child doctor. Okay, they specialize in developmental the child development. Okay, and then also they can see different types of this developmental difficulty or disabilities. Okay, like autism, learning disorder, like dyslexia and whatnot. Okay, so this is a very specialized doctors. Okay, when you see them, they will go through your child, they will ask your feedback, and then they'll go through the development. Okay, like I shared in the last talk that who joined us, uh, there's a few areas that normally doctor will check on. Okay, your language and skills, speech and language skills, your motor skills like fine motor, gross motor, all the physical skills, your cognitive, which is like your brain functioning, okay, your hearing, okay, and also the social skills. So these are the general areas that a doctor will go through. Okay, so this is why I emphasize to see a doctor because each child at the age, physical age, they have certain, they have to meet certain developmental criteria. Okay, let's say the child at the age of 3 years old, they can say at least 2 to 3 words. Okay, that's the in general, I mean the criteria. So let's say they couldn't, so that's where the doctor can detect that there might be a delay for the child in terms of speech and language. Okay, this child 3 years old supposedly able to speak 2 to 3 words, okay, but the child is not. So this is where they can detect each area and tell you. Okay, and also they can share you from as a doctor, they can share you the biological factor. Okay, like a lot of debate about autism, like whether it's due to vaccine, a lot of things, like a lot of discussion out there. So sometimes it can confuse parents. Sometimes it confuse myself as well as a counselor. Sometimes there's so many people. I meet a lot of parents that have different idea, opinions, and share with me. Sometimes I got confused too. So this is a time where I will refer all this concern to a doctor. Okay, especially a developmental pediatrician. Okay, this is where they specialize in the child's development. Okay, because when they can see, they can assess the area of development as well as they can let you know or they can rule out any biological factor, anything to do with biological factors. Okay, and the last uh, the last talk we have is on clinical psychologists. The difference between doctor and clinical psychologist is clinical psychologists can only see from the psychological perspective. They are unable to see from the biological uh, uh, perspective. So it's like nurture and nature. Okay, those nature or innate in a way, or they can call it we are born with it. Okay, as a clinical psychologist, they cannot see anything, any condition related to biological factors. Clinical psychologists are able to rule out. So this is where the doctors come in. So basically, it's like killing two birds with a stone. I'm not saying that you cannot see a clinical psychologist, but you have to know parents or teachers up there. You have to know the difference. Okay, and then from doctors, they can see from two perspectives. Okay, like psychiatrists, they can also diagnose children with like certain mental health difficulties, or also like autism and ADHD. They can see both ways, psychological factors and also biological factors. So this is the difference between the doctors and also clinical psychologists. Okay, but both are able to produce a diagnosis and then recommendation based on the diagnosis. Okay, I understand that a lot of parents find it difficult to accept diagnosis. You know, it's sometimes, you know, it's not easy to accept diagnosis. Okay, but what I would tell parents is uh, we want to emphasize on what is next. Okay, because that is the one that we can move on and then provide help to the child. Okay, be it any types of diagnosis, the most important thing is we have to know what to do next. So seeing a proper doctor, okay, and also a clinical psychologist, this is the process. Okay, diagnosis first, and then they will tell you what to do next. Okay, so this is very important for parents to know. Okay, the difference between two professionals, okay, and also what do they do, what do they provide, okay. And then in terms of developmental pediatrician, they are very highly specialized. They are not, they are, after pediatrician, they are specialized in the development. Okay, so this is where some of the parents, they come to me, it's like, oh, Charlie, the waiting list is too long, you know. Yeah, so yeah, I do understand that because this area, this field of highly specialized doctor is very rare. Okay, we have about 20 plus million population, and only I think 11 or 12 of them. Okay, and this is the important part. Okay, but if you cannot see a developmental pediatrician, okay, while waiting, okay, you can also ask a pediatrician what other area you can help your child with while waiting to see a developmental pediatrician. That's why here I personally emphasize a lot of parents talk to your doctors to understand more about your child. Okay, because by talking to them, you can gain a lot of knowledge. Okay, you can know what is the direction. Okay, and then most of them are quite, you know, most of them, you know, the treatment or intervention are in evidence based. Okay, it's scientifically support. Okay, but if you go to someone who are not like who are not in this area, who are not trained or have experience in handling children with special needs, uh, I'm not very sure myself, but I'm not confident as well if you know they are, but you know they want to suggest some type of a treatment for the child. Okay, because this is where a lot of misunderstanding, miscommunication from parents. Okay, and then recent research also show that the number of parents with children with special needs when they come out and seek intervention is very low. The number one factor is because lack of information. Okay, there is not enough information around. Parents are hesitant. Okay, one of the things is they don't know who to go for. This is also information. Okay, what to do, where to go, right? Okay, secondly is stigma. So these are the things that here in my story, we try to empower parents. Okay, by providing like us, we doing a monthly talk so that parents can know and make choices on their own instead of following blindly on the train. Okay, yeah. In Malaysia now, when we talk about special needs, there's a certain trend. Okay, when it's famous or it's expensive, that's where everyone want to go. But this is what I always tell parents: understand your child and understand how. What are you going to? What are the things that you're trying to do? Does it benefit your child or not? And then there is no harm in asking. Okay, whatever intervention, treatment, doctors that you're about to engage, there's no harm in asking them to understand more. Okay, all right. So today we have invited guest, Dr. Subhashini, Associate Professor Dr. Subhashini. She is one of a developmental pediatrician and from University Malaya. Hi, Dr. Subha. Can you hear me?
Yeah, hi. Morning, Mr. Wong. Can you hear me? Is it clear? Yeah.
Yes,
thanks.
Clear. Yeah. So today we have Dr. Shubha here to share with us about child development and also what she does as a developmental pediatrician. So for those who join us today, if you have any question, feel free to put in a comment box in the Facebook Live, and then I can read it out to Dr. Shubha.
Oh, morning, Mr. Wong, and morning to the Mindstory team. Thank you very much for this kind invitation. I was just wondering, shall I start sharing screen now?
Yes, yes, sure.
Okay, thanks. Okay, can I just confirm that you can see my slides?
Yeah.
Yeah, okay, all right. So thank you again, and I'm very happy to be here to be able to share some things with everyone. Please let me know if there's anything that you'd like to clarify. I will focus mainly on some of the main milestones and the things that you should look out for in terms of red flags and things which can, signal the need to see a doctor or a professional. But I'll focus mainly on a few aspects of development. So firstly, generally what development is, a little bit on normal development until age 5, and then I'll go on to the red flags, but I think I want to pay a particular focus to language red flags because I found that many of the people who present to us, many of the families usually have concerns about language, and the children usually present with speech delay as the first indicator, but it can mean a lot of other things. So I will spend a little bit more time there, but if you want me to clarify anything at the end, I'm happy to take questions. Okay, so just a little bit on development, because I think we have to think holistically. We have to think broadly speaking, not just about language and speech delay, which are obvious things when a child presents with delay, but we need to look at other aspects as well. So if you talk about motor movements, these are things like gross movements as well as fine motor. And fine motor are skilled hand movements. So if we consider gross motor movements, these are like things like crawling, sitting, standing, walking. And skilled hand movements relate to things which require the use of hands and fingers. So eating, drawing, writing, dressing, and this overlaps with some of the self-care skills. With speech and language, it's expressive language, particularly, so things like talking and words, but also we have to remember that language is not just speech. A lot of it is nonverbal, and communication, up to about 60% of communication can be nonverbal. So those sorts of things, even in children who have speech delay, often are intact, unless of course they have other social communication difficulties, like say for example in autism. And the nonverbal communication is a very good aspect to look at if we're trying to consider whether the child has delay that's more than just language. So body language, gestures, pointing, those sorts of things. Also with social, we look both at activities of daily living, so things like self-care, toileting, dressing, feeding, those kinds of things. But we also look at interaction, reciprocity, relationships with other people, and play skills. So play is a very, very important part of development, and it's very serious business actually. If you think, in terms of child development, children need to play, and if they're not able to play and they are deprived of that, they often fall back in other aspects of development. So it is one of their rights, and it is very important. And how children play with other children and how they cooperate for things can be very complex. And they learn a lot of organization, they learn a lot of skills that way, including things like language. So we usually have to look at this aspect. Of course, often we think, many people say play is just something kids do and they don't look at it. But really, please look at how your children play, because it will give you a lot of information as to how they interact, even before other aspects of development can surface as red flags. Comprehension relates to their understanding and learning, and this is not just academics. It's also how they comprehend the world, how they make sense of things, and their overall understanding. Okay, I've put this up because the CDC website is actually very interesting, and I'll show you the website again later, just as a resource for parents. But the important thing here is that development is a continuum, and children develop at different rates. Excuse me, and it's not always at the same time, but they tend to acquire those milestones at a fairly regular sequence if the development is typical. So when is it abnormal? And when we talk about red flags, we're talking about things which make us stop and wonder, is this child developing as they should? Timing is very important. So if someone develops at a slightly different rate from their siblings, that can still be normal because we have a normal range of typical development. But if the timing is very delayed, compared to what we would expect for a typically developing child, or if the timing of one aspect of development is very delayed compared to other aspects of development, then we know that there are issues there. So timing is important, like everything in life. Also, loss of skills that your child already had. So if a child has lost certain skills that he or she had before, that's very important. And that's the equivalent of an emergency in terms of development, because when somebody loses skills, it takes time to reacquire those skills, firstly. Secondly, if they've lost skills, it also means that there's a chance of them losing more skills. And we don't want that further loss of skills and attrition of skills. So we always have to, sort of sit up and pay attention to that. So if your child has started to lose skills, please go and see someone soon. You can see your general pediatrician, you can see your general practitioner, you can see, basically have this addressed and looked at rather than waiting and seeing. And I think sometimes families do come a little bit later, not so much because they didn't notice things, but it's that, sometimes well-meaning relatives have said, hold on, it's okay, this is normal. But I think you should trust your own, instinct on this, because generally speaking, the parents and caregivers usually know when something's not right. So why is it important to look out for delays and act? We're talking about all this, but why is it important? If it's not important, we wouldn't be discussing this. The reason is we want early detection. And the reason for early detection is not necessarily for an early diagnosis. The diagnosis is secondary. If you get a diagnosis early, it's good. If you don't get a diagnosis early, it's still all right, provided your child's strengths and difficulties are, assessed and identified, and they get the therapy that they need based on that. So always remember that, seeing a doctor doesn't necessarily mean that you must get a diagnosis. There are also times where children present and they don't quite fit into any particular diagnosis and any diagnostic category, and that's okay. Sometimes we won't give you a diagnosis at that point, but we'll be able to help identify what are the things that your child is good at and that you need to support a bit more, and then what are the aspects that they need extra help with. So that's how the therapists and counselors and everybody else comes in, because they can support you in those specific areas. And the reason for early intervention is that the earlier you start, the less likely they are to lose skills, and the more likely they are to pick up skills. It does not always mean that the development will go up to normal, but I think the whole aim is that we want to optimize the development for that particular child as much as possible. So it is individualized, which is why, we don't just say everybody goes for occupational therapy or everybody goes for physiotherapy or speech therapy or behavioral therapy. You need to see what is the rationale behind it and why certain therapy is important. And the reason for all of this, again, is we want to improve the prognosis, because this child cannot speak for himself or herself. And I think that's why parents play a role as advocates, and also therapists, doctors, everyone else in health and allied health have that role, simply because if we don't pay attention, we don't do something, we're going to lose that time. Okay, so I'm going to go a little bit into the development at different ages. This is just to give you a bit of an overview. I know there's a lot of words here, but I've left it there just in case anybody wants to go back and look at this later. But I'm just going to pick up a few things, and then I'll go a bit more into the language part. So at 1 month, this is just, within the newborn period. If a child an infant has a very stiff neck, it can signal something wrong with tone. So if they stiffen their back quite a bit, that's a bit unusual. Of course, I don't expect parents to straight away bring an infant for an assessment at that point. But if you're going to, say, like the government health clinics, normally the nurses, when they assess, the maternal and child health nurses will be able to pick up these things. And of course, if something happens at that time and you notice something unusual, ask questions. I think that's the most important thing. If you feel something is not right, ask, because often healthcare professionals and allied health people may notice things, but they may not necessarily communicate that and explain it simply, because of time and things like that. But I think if you ask, most people will be quite willing to explain. At the same time, sometimes you may notice something which they don't notice, because they're going to see your infant or your child for maybe 15 minutes, 20 minutes, but you're observing your child for such a long time throughout the day. So it's always important not to feel afraid or to feel that, it's a silly question or anything like that. No questions are silly. And I think most of us appreciate when you highlight things, because then we know, you may raise a concern which we may not have noticed. So please ask questions. Also, for an infant, if they do not have what we call a red reflex when they check the eyes, then those are things that we need to look into as well. And this is important because it has implications for vision later on. And vision has to be addressed early. Even hearing impairment needs to be addressed very early. The longer you wait, the less likely you are to preserve whatever vision and hearing that you have. At the same time, it has implications for the rest of development, because if someone has difficulty exploring the environment and the difficulty seeing things, then they're not so able to learn. And it can impact them in that sense, especially when they're very young, because a lot of learning happens in the newborn period and early infancy and early childhood. Also with hearing, if an infant or a child has difficulty with hearing, it can impact their language development. And sometimes something like that can also cause speech delay. So not everybody with speech delay has isolated speech delay. And I know sometimes that is usually the presenting complaint or the diagnosis that we're presented with, but it's not always the case. At the same time, not everyone with speech delay has autism. So I think you really need to be vigilant for these things. We need to be vigilant for these things, but parents do play a big role here, because you notice things that other people may not. Right. So at 1 month, the typical 1-month-old should cry from birth. They usually make grunting sounds, so some sort of vocalization, and they should be able to turn, when there's some eye movement with slow turning of the head. So if you turn the head, when they turn towards sound, they tend to move as well, not fully to localize, but you will see some orientation to sound. They do make baby noises from about 1 to 3 months. And if they do not say anything, if they're very quiet babies, like what people would call very good babies who don't make any noise at all, you have to wonder whether there's something not quite right. Of course, they could be temperament-wise, they could be very, very good in that sense, but we need to also be a bit skeptical about the babies who don't do anything and just keep quiet all the time. And response to sound is important, so they should have some response to sound. They should startle at least, even if they're quiet. If there's a noise, they should startle. If they don't pay any attention to that, then we really need to look at hearing. And I just want to emphasize that the newborn screening of hearing it's a screen. So it's not a diagnostic test, which means that many infants who are screened as normal hearing when they're born can still later on have hearing issues. It doesn't mean that you have a normal hearing screen at birth, the hearing is completely normal. In most instances it is, but there are times when there are other problems with hearing later on. So when a child presents with speech delay, or we suspect that there are difficulties with hearing when they're a little older, even if they're 2 or 3 years old, we do tend to send them, for a repeat hearing test. Okay, so at 3 months, infants should be reaching out for things, not purposefully picking things up. You wouldn't expect them to reach out and pick up an object neatly, but they should be batting at things or swiping at things. I mean, sort of putting their hands out and trying to reach and get stuff. And if their hands are always in a fist, that's also an indicator that maybe their tone is unusual. Also, not focusing on faces, not looking at people, can signal difficulties with vision. And of course, other than difficulties with vision, some of the infants who have difficulty bonding and difficulty with, with interaction for various reasons, can sometimes not focus as well. So we need to differentiate whether it's a visual issue or if there are other concerns. I think I've mentioned some of these other things. So that's the main thing here, is they should be able to turn to a source of sound. So if, for example, I hear a sound over here, I should be able to turn, and an infant should be able to do that at 3 months, unless they have difficulty with hearing or they have difficulty with head control. So if your head muscles are not so stable, or the tone is increased, they can also have difficulty turning. And a lot of this has to be integrated, because sometimes we need to unpack that and sort of figure out what are the deficits which are in the, that are causing these problems. And that's the role of the doctors as well as the therapists and everybody else. But the role of the family is just to highlight these things. They should try to imitate some sounds, and they should be making some nasal sounds. So not quite language, but these are some of the things which approximate some sounds and components of words and language later on. So they're already beginning to acquire some language at 3 months. So at 6 months, same things, like not reaching out. And when you pull up an infant, the head shouldn't fall back. So if you hold an infant and the head flops back at 6 months, that's unusual because they should have some amount of head control at that time. It shouldn't be really rigid or stiff, but they should be able to, when you pull them up from the lying position, they shouldn't have the head fall right back. Also, again, with reaching out, exploring things more. If you offer a cube or a block, so sometimes it's called a cube, a block, a brick, it's all the same. It's those colored blocks that you can get, usually about 2 to 2.5 cm in length. If you offer that, an infant should be able to take it with one hand, and then if you offer, so they take it one hand, if you offer in the other hand, they should be able to take it in the other hand. If they only reach out with one hand, they don't with the other, then you should also wonder whether there's weakness in the other hand. So these things are also important very early on. And often people say babies don't do much, but they really do a lot of things if you're looking. So if they don't have any sounds other than crying, and they don't have any babbling or repetitive sounds, we need to pay attention. It may not necessarily be abnormal at this point, but usually by at least 8 months, you would hear some babbling. And there can be a little bit of variation here, but the idea is just to take note of this and give them more stimulation in terms of language and interaction and see if they respond. Often they will try to copy your intonation. Of course, they won't be able to say the words, but they will be able to copy your tone and intonation and respond in that way. And any infant at 6 months who's not interested in their surroundings, will warrant further assessment. So disinterest in surroundings can be due to many things. One, of course, could be that they have visual issues and therefore they have difficulty looking around and exploring their surroundings. The other thing, of course, is that if they have difficulty with reciprocity, which is like the two-way interaction, responding when someone does something, responding to that and interacting further, then they can have disinterest in surroundings as well. Okay, so also when you take something away, they should look for that. Like, say, for example, if you have a toy, you bring a toy here and they're looking at the toy, and then you call them and you take it away, they should come back and look and see where's the toy. And that's important because at this age, they have what we call object permanence. So they know that if they don't see an object, it doesn't mean that it doesn't exist. So they should have that concept, and that's a cognitive concept. Okay. Here, I think they should be able to localize sound and turn to voices. And they should be making some vowel sounds. So, the A-E-I-O-U sounds and some consonants, which are the other letters other than A-E-I-O-U. They can sometimes have consonant vowel combinations. So these are like where the first letter, like for example, if you say ba, B is a consonant, A is a vowel. Similarly for da, D is a consonant, A is a vowel. Ga, G is a consonant, A is a vowel. So these sorts of combinations are the beginning of babbling. And when doctors ask you whether your child babbles, this is what they mean. Are they making those sounds? If they're just doing the kind of sounds, those are just consonant sounds. And if they're just doing E, A, O, those are vowel sounds. But when they combine them, then they're consonant vowel sounds. And then they should be imitating, as I said. Even turn taking when vocalizing. So that's the beginning of conversation. And if you look, you can even see there are lots of very interesting videos on YouTube where you see children who are non-verbal having conversations. And their conversations have a lot of non-verbal components, a lot of give and take, a lot of interaction, gestures, expressions, pointing, and what we call joint attention. So one person will point and then the other infant will look. They really look like they're having a conversation, and they should be doing some of these things. Of course, at 6 months, their motor skills will be a bit limited, but you will have a bit of that give and take in a typically developing infant. At 9 months, not being able to sit on his or her own may indicate some difficulties with tone. And I say a lot of things as in may or might, simply because we need to see in context. Of course, for infants who are premature, and say if they're very premature, a lot of these milestones have to be corrected for that prematurity. So even if a baby is 9 months old, if he or she were born very premature, we need to minus that time and then say, okay, this is the corrected age for that infant. So we wouldn't expect a premature infant at the same age to be doing something that a term infant would be doing. But by the time they're 2 years, the premature infant should have caught up. So if by 2 years they haven't caught up, then we don't correct anymore, but we still expect them to perform at the same level. And that's important because if they don't catch up, we can't keep saying, forever that they're premature, so they'll be late. We need to start concentrating on improving those skills. Okay, so picking things up neatly with fingers. And when I say picking things up neatly, it's basically if you have something here, they should be able to do that, to pick it up neatly. If they're just doing this at 9 months, that's not normal as well. Or using their palm, like picking up an object like that. And if they should have some exposure to things like bye-bye, peekaboo, those sorts of games. And if they're able to do that, that of course will depend on exposure. But even if you're not doing those kinds of things, most infants by this age would be exposed to no. Like say if a parent says no, do they stop? Do they hesitate? So then you know that they understand that. Okay, stranger anxiety or being afraid of strangers depends on temperament again. Some infants go through this phase, some don't. And if they don't go through this phase, it may not be abnormal. Sometimes it is just how they are, that they're friendly, they're quite comfortable with people. But it can sometimes also indicate that they're not so aware of who are their main carers, who are other people, who are strangers. And that can be a social communication difficulty as well. They should be exploring things. They should be very, very curious by this time. Okay, so I think I've mentioned some of this earlier, but this response to social attention is very important. And if you really go back and see if you have young children or infants and when you interact with them after this, try and look out for these things. You'll find that they are actually very communicative in their own way. So, people always talk about speech, but I think that's just one component. We have to really look at the other things. And I'm emphasizing this many times simply because I feel that a lot of the very, very early signs have nothing to do with speech. If you talk about communication and you pick up on these things early, even before the typical age that a child would speak, which is 1 year plus, sometimes some of these difficulties will arise. And of course, if you see that early and you seek attention earlier, chances are of us picking it up earlier will be better as well. Okay. Right. So at 1 year, not being able to stand on their own is something that's unusual. Not every child walks at 1 year, and that's okay. Many children walk at 15 months, 18 months. That's still considered within the normal range. But whether you want to consider it delayed or not will also depend on the context of the rest of the development and the acquisition of skills. So the rate that they're acquiring skills will give us an indication as to whether overall they have delays and they have difficulties or not. They should have some words with meaning by this time. And when I say single words, it's basically just one word. So not 3 words together or 5 words together, but in total, they should have at least 3 to 5 single words. Also with eye contact, it should be very good by this time. And often eye contact, even in infancy, is very good. If they're not interested in their carers, they don't really mind if the main caregiver leaves the room, they don't notice. That may be unusual. Of course, you have to take this in context as well. If the parent is not the main caregiver and say someone else is the main caregiver, they will probably more attached to that person. And that person, like say the grandparent or someone else, will be the person that they sort of want to be around more. And if that person leaves, they should notice. And of course, when I say notice, doesn't mean that they scream or cry. That's not necessary. It's just that they should pay attention and at least show some sort of recognition and notice that the person has left rather than be oblivious to it. Okay, so again, the meaningful words, and they should try to imitate words. Okay, so with imitation, sometimes we use the term echolalia. You may have heard some of the doctors saying that. And echolalia is when it's basically echoing speech of someone else. So if, like, say somebody says something and the child repeats it immediately, that will be considered echolalia. Or if they hear something on television or somewhere else and they repeat it later, that would also be echolalia, but it will be delayed echolalia. The important thing with echolalia is that it's usually without context and without meaning. So they just repeat it because they hear it and they repeat it. When someone repeats it in context or they use it in a proper application, we don't count that as echolalia. But this one, in terms of imitation of words that others say, initially they can have echolalia when they're this age, but that echolalia should slowly diminish after that. And usually by the time they're 2, it should have completely disappeared, except for kids who sometimes randomly do it because they think it's funny, or they hear a new word and they think it's interesting and then they repeat it. But it shouldn't be done just like that all the time. And if they do it all the time without meaning, then we need to look to see whether they have social communication difficulties again. They should be able to understand one-step instructions, and they should be able to look at things that people point to, and they should be able to point to indicate things that they're familiar. So like a familiar person, a familiar name, all of that, objects, they should be able to identify by this age. This is at 18 months. Okay, so scribbling, the important thing here again is exposure. If a child has not been exposed to pencils, crayons, or maybe people are worried they'll scribble on the walls, then we cannot mark them down for not being able to scribble at this age. But provided they've been given adequate exposure, if they have difficulty to use one hand, they only reach out with one hand, not the other, or they have difficulty holding a pencil or a crayon to scribble, then there may be some fine motor difficulties or difficulties with the movements of their fingers and hands and control. Not being able to pick up small objects, like remember when earlier I mentioned about having a neat pincer and picking things up neatly. By 18 months, they should be able to do all of this without even thinking. And they should be able to take things like, say, a raisin and put it in a container quite easily. If they have a lot of difficulty picking it up, we need to look to see whether there are motor difficulties or whether there are difficulties with vision. Of course, some kids will refuse to do it, and if they refuse to do it, it could be an attention thing, or they are just not engaged in the task, or it could also mean that there's some difficulties with interaction. It really depends on the situation as well. But say, for example, when they pick things up, if they pick it up, say they pick up the object and then they have to keep adjusting like that and putting it in, or some kids take the thing and they put it against their chest to adjust and put it in. Those are all compensatory strategies, and they indicate some difficulties there. With words, they often start 2-word phrases at this time, but even if at 18 months there are no 2-word phrases, if a child has a 2-word phrases by 2 years, that would still be considered typically developing. Okay, and imitation should be very good. Like say if water spills on the floor, someone picks up a cloth to wipe it, they should also try to look for something and imitate and try to do those things. So imitating people in their daily activities, wanting to do things, to copy what other people are doing, are all typical things at this age. Sometimes at 18 months, children have some make-believe play, but their make-believe play is basic. So it will be things like maybe taking a cup, a spoon, pretending to stir, pretending to feed themselves, or to feed their doll or teddy bear, or to feed somebody else, or pretending to cut or do things like that. But it's still important, because if they're not using their imagination in some way and they don't have any sort of make-believe play, that is not typical for an 18-month-old. And again, it can be due to various reasons as well. Also, if they're only playing on their own and they're disinterested in playing with others, that can signal difficulties. Not always, but sometimes children with autism do present that way. Of course, you don't expect an 18-month-old to be playing interactively. I mean, they wouldn't be doing things like playing police and thief or, doctor and patient or those sorts of things at this age, but they would still have some give and take in their play skills at 18 months. Okay, so they should have up to about 20 single words. Some children have more than that, but if they have about 5 to 20 single words, it's still okay at this age. Intonation will be tone of voice. So it's like, say, for example, when say I talk very softly and then I increase my volume and then I change my tone, that's intonation. And they should have different kinds of intonation at this point, used appropriately. They should also be able to point to pictures and common things, not some, not things which are very vague. So whenever we test, we usually give common objects, which we would expect any child to be able to see around the house or elsewhere. Now, of course, we have to modify things a little bit, because for the past 2 years, most of these children have not really been anywhere other than home. So we can't really, even you show them things like an aeroplane or a butterfly, which previously would be common objects, we sometimes need to modify and show them like a cup or a ball instead, because they may not have had exposure to those things. So they should have some indication of body parts if they've been taught this. and then some phrases. Okay, here I think it's just the important thing at 2 years is mainly to look at the words. They have a lot of words, and there's sort of an explosion of language and vocabulary at 2 years. They really start talking. And if they're only saying single words or they're not talking at all, then we need to assess that further to see whether it could be a hearing problem or whether there are issues with communication in other ways, whether it could be autism, whether it could be social communication disorder. There are lots of possibilities, but we need to look at that. But ideally, we don't want to first see a child at 2 years for these issues. If there were red flags earlier, we'd like to see them a little bit earlier so that we can advise families on the strategies and which sort of therapy is indicated. Dry by day is off diapers in the day. This again is it's cultural, so it depends when it's taught and what are the practices at home. Different families start this earlier, but it's important to see whether the child is aware that they're wet, aware that they're soiled. Those would be more indicative than when they're actually dry in the day or dry at night, because that will depend on the toilet training practices at home. So here they should also pretend that objects are different things. Like they might take a block and pretend to, take a block and pretend to sort of text, like they're using a mobile phone, or take something and pretend it's an aeroplane. So those sorts of pretend play tend to evolve and emerge at 2 years. And by this age, normally not just 2 words together, but they often have 3 or 4 words together if they're exposed to language. The crucial thing here is that as in many households, the children are exposed to more than one language. So if you're exposed to more than one language at a time, sometimes the words in that particular language, which you see them in isolation, may not be as much as, say, a child who's exposed to only one language. But if you add those 2 languages together and you talk about the total vocabulary for each and you add it up, it should be more or less the same as the vocabulary for a child from a single language family. That means that overall the vocabulary should be about the same and their use of words. It's just that they may not have it all in each language. But that's something that tends to improve over time when they learn a bit more in each language. Of course, for the kids who have difficulties with language, it can sometimes be a bit more challenging. But we don't usually tell families don't use this language or don't use that language, because I think it's important that the carers use the language that they're comfortable with. If a parent or a carer forces themselves to use a language that they are not familiar with, they're not really giving high quality language input anyway, and they're making things very difficult for themselves. So as long as whichever carer uses the language that they are comfortable with and they use the language properly, it's fine. I think that's something we have to be practical about rather than trying to change everything when it just won't work. Okay, so they should be able to follow a 2-step command at 2 years. Okay, so 3 years, more of the physical motor skills tend to be more apparent at 3 years. But in addition to that, they also, they talk a bit more. Their self-care is a bit more at this age. Things like dressing, toileting, brushing teeth, putting on clothes, taking off clothes. They usually need a little bit of help, but you'll find that those sorts of independence and those skills improve as well. If they have difficulty balancing on one foot, even for a few seconds, then we need to look to see whether there are difficulties with their coordination, balance, motor planning, or physically whether there are weaknesses or not. And they should be able to understand that if they do this, there's a consequence for that. And often, if they've been exposed to writing implements, they should be able to copy a circle by this age. Some kids can even do a cross, but normally a cross is about 4 years. They should be able to copy certain letters like B, H, T, but again, there's some variability there. So we would really look at how they hold the pencil. Are they comfortable with the pencil? What's the pencil grip? The handedness, are they using one hand, both hands? Are they able to position themselves accordingly to do these things, or do they need to compensate, like lean over the paper to do stuff? Are they able to copy? And when they copy, how smooth are the lines and what's the pressure like? So a lot of things go into these observations, and occupational therapists will usually be able to give you a lot more info there. Okay, so here they usually have the beginnings of sentences, and pronouns and plurals will be things like he, she, me, you, I. Again, depends on the language of use. If English is not the main language used at home, then with a lot of other languages, pronouns are not used as much as English. So we may not, mark that in terms of deciding on the age of development. Plurals will be things like, plural and singular. So is it one or is it multiple things? Again, sometimes if English is not their main language of use, then plurals can get a bit confusing when they're using English. So these things also depend on exposure. They should be able to know their name. And narrating is like telling a story. So for example, if the child comes home from kindergarten, can the child tell you what happened at school? Like the friend did this, he fell down, he started crying, the teacher gave him a plaster, those sorts of things. Are they able to tell a story that people can understand or at least make out generally? So that would be narration. 4 years, most kids, if they're exposed to stairs, should be able to go upstairs without difficulty. But again, many families don't allow children to climb stairs because they're worried they'll fall. So sometimes we take that with a pinch of salt. They may not be able to climb stairs, but then we have to see if they're accompanied and they're a bit more confident, are they able to do it? And we look at the fluidity of the movement going up and coming down. Also, we look at their grip when they're drawing. And at 4 years, most children can draw like a circle for a head, maybe eyes, ears, nose, and then 1 or 2 body parts. So things like arms. So if it's 3 parts, it will be arms, the trunk, and the legs. Again, we look at how they hold the pencil. And then language, more complicated language at this time, they should be able to understand simple jokes, not very complicated jokes, but basic jokes and humor is something that a 4-year-old will understand. Of course, their humor may not be really funny to you or I, but for them it's funny. And sometimes when people make a joke, they will look at everybody else and sort of laugh. So they have some appreciation of humor. If they still have some confusion with make-believe and what's real is normal. So it's very important not to tell a child that he or she is lying or making up things or they're being untruthful. At 4 years, they have a little bit of difficulty, differentiating reality from make-believe. So sometimes they will tell you very earnestly that this happened, that happened, and they really believe it. And it just means that they're at the appropriate developmental stage in terms of their learning and their understanding, that they are already exercising that imagination. So it's something that is, it's good to see. But if we say, don't say this, don't tell lies, sometimes you discourage them from being creative. Of course, there's a limit. You don't want them to be untruthful, but it's important not to say things, to tell them to stop doing this, stop doing that, because that can curb creativity as well. Okay, so 5 years is the last one I'm going to go through before I talk about something slightly different. They should be able to touch their toes without bending their knees. So standing, they bend over without having to bend. They should be able to touch their toes. And at 5 years, many children, if exposed, should be able to ride a bicycle. If they ride a bicycle with trainer wheels, that's fine, but they importantly should be able to cycle. So put their feet on the pedals and cycle. And then drawing at this age, usually they would be able to do a circle across those letters that I showed you earlier and a square. And then even drawing parts will be more complex at this age. Their sentences should be fluent and quite grammatical, but this will also be dependent on how how good or how rich the language exposure is at home and at school. And often they're able to dress without too much help at this age. If they have difficulty with buttons and zips and hooks, then we need to also look at the fine motor skills. Recognizing colors, a lot of these things, playing independently, not really needing people to be around all the time to see to their needs and to entertain them, are important skills at 5 years. And also with play, they normally have very complicated play and sometimes even fantasy play at this age. Okay, so what should you do if you identify any delays in your child? First of all, don't delay. I think many people feel they don't feel confident or empowered enough to go and seek help. And when they're reassured and they're told, it's okay, they of course, everyone hopes that there's nothing wrong, so they will believe that. But I think I've also seen families where they've been falsely reassured sometimes by healthcare professionals to say that there's nothing wrong. And I think that if that's something that you've heard, but you really aren't convinced, then just go and get a second assessment. So if you're in doubt, you should see your general practitioner or your pediatrician or any other, anyone else who will be able to assess you. And if needed, the doctor or the health professional will ask for things like a hearing assessment, speech therapy if necessary. Sometimes if we worry about vision, then we'll ask for an eye assessment. And then we can refer for things like occupational therapy and physiotherapy if necessary. But, more therapy does not necessarily mean it's better. It needs to be, targeted therapy that addresses things that need to be addressed. So just sending a child for 20 hours of therapy a week or 40 hours of therapy a week with just this battery of things may not be what it's appropriate, because everybody gets exhausted and it doesn't always work. So that's where the specific professionals in these areas will be able to tell you that your child needs a bit more work in this area, so let's focus on that. We want to consolidate these skills, but we need to work a bit more on these. And that's very important, rather than just making someone do all the therapy. Because sometimes families also go around to different therapy centers and they feel that the more therapy centers they go to, the better. But it's not very coordinated. And I think that communication between all the professionals is important. And, you need to have an overview as well. So those things are very crucial. And, it's when you talk about therapy also, it's not without a cost. So I think you need to balance those things out as well. Okay, so these are just a few useful websites. I will show you maybe snapshots of the websites in a second, but the CDC website is very good. Raising Children is a free website for parents and has a lot of parenting information, not just for children with developmental issues, but also for typically developing children. And then the WHO e-learning caregiver skills training is very good because these are practical things that you can do at home. The 0 to 3 is a really nice website, which, when you have time, you should look through if you can. Unfortunately, a lot of these resources are in English. Some of them have some translations, but not in all languages. So this is the CDC website. If you look at this website, they have a milestone tracker app, which is free. And you can download it on your phone and put in your child's development, what milestones they've acquired at different ages. And it's a good way of charting the milestones. So when you see a doctor or you see a healthcare professional, you can sort of show them and say that, this is what my child's been able to do. And, these are the things that I'm a bit concerned about. And it's a good record for them to see, because it's not easy, I think, to recall everything. Like often we'll ask parents because we need to know when the child did certain things. But when you ask them at what age you think your child did this or that, it can be a little bit difficult. And it's also difficult when parents are working and the main carer is someone else. So if you have this tracker, you can ask the main carer to fill it in, or you can come back, now and then and say, have you noticed the child doing this, and then you have a record. So it's an objective record. This is the Raising Children's Network. They have a really nice section on autism, but they also have a lot of important information, not just for newborns and later, but even for pregnancy. And they have some free training, very short videos for parents and information there as well. So it's constantly being updated. It's a very nice interface which you can use. This is the caregiver skills training for families. It's self-paced, so you can log in, do it when you want, and then continue. And it's 8 hours in total. They, of course, have a certificate and things like that. But I think beyond that, the most important thing is that when you do this, you're able to take that information and work with your children. And, when you say like doctors, therapists, everyone is there to help you and support you. But you're the ones who are with your children all the time. So, the people who really can do these interventions on an ongoing basis and incorporate it into daily activities are the parents. And I think that's that's very powerful, because you can use these skills all the time. And that's what makes it effective. It's that consistency. Okay, so 0 to 3 is here. And then that's all. Thank you. I'll stop screen sharing.
Yeah. Thank you so much, Doctor, for sharing. It's really good to
for us to learn 0 to 5 years old, and what are the red flags? Because I think this is very important, not only for parents, but also because nowadays more and more child are going to career center, because both parents are working. So at least, if they see or they notice something indifferent, they can relate to the parents. Yeah, and also teachers when they notice something at school, because nowadays um, we no longer have MCO, PKP. Everyone is going back to school, so sometimes it's also beneficial for teachers to detect. Okay, and also yes, I do agree with where there's a part about when you're in doubt, please talk to the professional, the health professional, because when I working with parents, a lot of parents, not all, sometimes they'll just say that, or they will grow out of it. My child will grow out of it. Eventually, it will be normal. Or some of them will say that I used to be like that too, but I grow out of it. So, but if you need more information, like what Dr. Shubha has shared, if you worried or you're not very comfortable talking to a doctor or a counselor or anyone in this field, you can check the website out. So you can go through and see. And because the most important thing is it's evidence-based, okay? Because we are in a multicultural country, definitely a lot of cultural influence, okay? Like, this culture has different kind of belief. We are not here to correct anyone. We just want to share the information out. So parents, if you have any concern or you're not comfortable, there's always alternative to seek for information. Okay, like I shared in the beginning, when we just started, the number one barrier for parents with children with difficulties to seek intervention, number one barrier is lack of information, because they're not sure what's going on. And then some of them, uh, it's not that they choose to leave it, but they do not know what to do next. Okay. All right. So we are here in the Q&A session. We have a question, doctor. It's my child is mild autism, now at 6 years old, suddenly cheeky to say the opposite on purpose. Can I know why?
Oh, okay. Thank you for the question. Can I just need to clarify, you're saying that saying the opposite, meaning that when you ask the child to do something, the child does the opposite. Is that the
I think so, because
oh,
they just
okay.
put in one sentence.
Okay, yeah.
And then on purpose, yes.
Okay, so this may or may not be due to the autism, because sometimes children do this at different developmental ages, and often you find that when they're slightly younger, they tend to try to be contrary. Like you say do this, they'll say no. Everything is no. It's something that's very prominent during the toddler phase, but it can also continue to say sometimes 4 or 5 years, and of course later on when they're a bit older, it can get a bit more obvious in other ways, like when they're teens also, they tend to sometimes be oppositional for a period of time. But it's possible, because I haven't seen the child, so it's possible that because of the ASD, because of the autism, he I assume this is a boy, or I'm not sure it's a boy or girl. Oh, okay. So he or she may have some delays in other aspects, even though the autism is not severe. It's possible that they have delays with the rest of development, and that might indicate, why he or she is performing at this developmental stage at 6. It could also mean that he or she has difficulty understanding language, and sometimes it may not be intentional. It could be that they're just doing the opposite because they're still trying to decipher what it is that you want from them, and they may be doing something else. So I mean, I'm not sure whether that answers your question, but I think it's just that what I'm trying to say is that, I don't think he or she's being naughty. We need to sort of figure out what are the reasons. The other possibility is it can be for attention, because often children find that when they are, they do what we consider naughty things, or they do things which are against what they're asked to do, they get much more attention much more quickly than when they do what they're supposed to do. So it's important to catch children being good. Like when they do something good, you need to say, oh, good that you're doing that, or I'm happy that you're doing this. And you have to be quite explicit with the praise. So you need to say that it's very good of you to help your brother with this, or it's very nice that you sat down quietly and you were drawing. Then they know what activity it is that you want them to do and what behavior it is that they are getting praised for, and they're more likely to keep doing that behavior. Whereas if when they're good, no one pays attention to them, and then they do something naughty and they get attention, they learn to do the naughty things to get that attention. Because parental attention, whether or not it's to correct, it's still very powerful, and it's something children actively seek out. Whether you're scolding them or not, it's still attention.
So the parents share example, like for example, red is, they will say opposite green or different.
Oh, okay.
And
Yeah.
then
So
they also
sorry.
say that he knows, but in a cheeky way.
Oh, okay. Yeah. So this may be more the attention part that, he thinks that it's funny, or it's just a humor part. Maybe he's at the 4-year-old level humor where he thinks that if you say this, I say the opposite, it's fun. It could be that, because sometimes humor is not something that all people with autism pick up on. And of course, I'm generalizing, and it's, even if you're neurotypical, you may have difficulties with humor, but those things are often stuff that we see, and that may be why he's doing it. But it could also be for attention, or it could be that he's trying to tell you he knows the opposite. So if you look at it that way, then it's not something negative.
All right, thank you. So if you have any questions, feel free to comment. I have also a set of questions from parents texting us. Okay, I'll start with something play. Okay, because just now, doctor, you mentioned about play is very important for child. So and we can learn a lot, or we can observe a lot when a child play. So a parent asks, how long will a child play? Like, what's the duration? Like, does it go above 5 years old?
Okay. So there's no like upper limit for play. I mean, when you look at it, sometimes even adults go and they do like, what is that laser tag and all those sorts of things, right? So, it's something that people do. You don't just stop at 5 years, suddenly they don't play. But it is more the sophistication of play and what sorts of things they're doing that we look at different ages. And it's important for them to continue to have fun and continue to do things. And when we say play, they might also be playing sports, organized kinds of activities. That's all play. So they don't stop at 5 years. That's a short version of the answer.
It is good. And then follow up with that. Can a child learn through play?
Yes, so they can learn to play. Often they learn on their own. It's something which children pick up by observation, by interaction, by trying to join in, by imitation. And initially they observe other people, they have a little bit of interest. Then they have what we call solitary play or parallel play. Solitary play, they play on their own. Parallel play, another child is playing, they play next to the child. And it's not really an interactive or shared activity, but they are still learning a little bit from each other sometimes. Then you can have what you call associative play. So they come and join in a while and then they go off. And then later on, they have more complicated types of play, cooperative play. So by exposing them to situations where they have the opportunity to play, even for children who, for whom this doesn't come instinctively or as easily, they can learn to play. And that's why we try to encourage, either kindergarten attendance or, sessions where they have social skills training or things like that, particularly for the children who do not have exposure to the same age peers. Often also, if they're exposed to just older children or adults, they can learn. But it's important for those older children and adults to try to remember what it was like to be that age and try to do the activities that they think would be fun and engaging for the child. And they can learn. They can learn by imitation.
All right. And then a question follow up from that is, I'm looking for a kindergarten. Nowadays, there's a lot of different types of kindergarten, play-based or academic-based, 4 years old child.
Okay, so generally speaking, play-based is usually more it's more organic in that sense that they sort of learn from play, they retain a bit more information, they're interested, they're engaged, so they pick up more things. Academic based kindergartens, I mean, not to say that they're bad, but I think you need to see your child and whether he or she can fit into that sort of setup. If you ask me, I will always say try to go for a less intensive kind of kindergarten, because I think children learn best when they're happy and they enjoy themselves and they can do a lot of other things. And when we tend to pay attention and retain information if we're interested and we're engaged. So if we're not interested, we might memorize it for a short period of time, but we're not going to internalize the information. And it's very important, even if you look at the evidence, like say, if you look at the education system in Scandinavia, they do a lot of things which are play-based, a lot of things which are unstructured. But later on, when they're in secondary school, they do standardized tests. They sometimes, they do just as well as everybody else. In some instances, they outperform others. So it doesn't mean that early on you must start, hot housing kids and say, you study this, memorize your ABC. It can sometimes kill creativity, and creativity is very important later on for higher order thinking skills and for thinking out of the box.
Correct.
Yeah, so play-based.
Yes. So yeah, I do relate with this when I'm working with parents and family, and I have to say that culture play a very big role here. If you're coming from a very academic background, definitely it will influence parenting in a way that they want to instill academic as early as possible. But from what Dr. Subha have shared all the red flags just now, what I can suggest is if you found out that your child has difficulty learning, I mean, there's no harm in changing to play-based because it's obvious that if they're having difficulties, no point pushing on because it's 4 years old preschool, and the child is at the edge of where they enjoy a lot of playing. So there's no harm of looking for play-based, and then slowly maybe when he is ready, then maybe we can transition back to academic based, because it provided that no, not provided that it's like also because we have 2 years of PKP or MCO, so definitely the child has not exposed to a lot of areas. So,
Yeah,
okay.
but
Yeah.
oh, sorry, just I mean, I think it's if it's okay, I just want to make one point. I think
Yeah.
it's important that learning is lifelong. So sometimes emphasizing all these things very early, after a while, when the child feels that, oh, I'm done with exams, finish, they stop actively seeking opportunities and learning. And I think you have to try to make it interesting and fun so that they are curious and they keep learning because they want to learn and they're thirsty for knowledge. So that's important. Yeah.
Yeah, I do agree with that. It's like developing interest, and like what Doctor said, it's a lifelong. So if it's instilled to a person and they do not enjoy it, it will not be lifelong. Like I said, someone shared this with me before. It's like eating vegetables. It doesn't taste good, but in the long run, it's healthy for you. But you don't see that immediately. Okay, you can see it in long run. Okay, so that's how I get to understand the concept of it's not that we are not pushing academic, it's just that why not we try something out for the child to be comfortable before we push again.
Yeah.
So the next question is, my child is 9 years old, diagnosed with developmental delay. He enjoy playing, and then has very little interest in academic learning. Should I continue playing or should I continue academic learning?
Okay. Thanks again for the question. I mean, I know these are SMS questions, right?
Yeah.
So I may not, I can't get further information. So I'll give you some general things.
Yeah, sure, no problem.
But it'll be good to know if, currently what is the academic setup for this child. Is he in a special education class? Is he in a mainstream class? Or whether, he's in non-government, but maybe it's like homeschool or private school. So those things come in as well. Whatever situation or environment he's in, if he's currently happy and he's thriving and he's keen to go to school, and you find that there are some improvements in terms of skills, he's improving incrementally, whether or not it's big improvements. If you see some improvements, I think you should probably leave him where he is. But what you can do is maybe add in additional support. So if you find, and say the teachers or the therapists have or the counselors have identified that he needs a little bit more work in certain areas, then you can add that little bit of extra support, but try not to change the environment too often. I know many times parents do it. I mean, it's well intentioned. They do it because they feel that they don't see much change and they're worried that they're wasting time in that environment. And of course, when we all say don't waste time, address things early, I think we sometimes add to the problem because we're adding pressure, which we don't intend to. But the idea is that you don't want to take a child out of an environment in which they're thriving and transplant them somewhere else, because there will be a period where they need to adjust and they need to, make friends again. They need to do all those things, which are very, very important also. So the most important thing will be to just see how you can optimize the environment they're in and then try to give that support. If, say, of course, it's different. If, say, like in this case, this child is happy where he is, that's fine. But if he's not, if you find that, you're seeing improvements objectively in assessments, but the child is miserable, then you may need to start adjusting and taking things off and making those modifications.
Yeah, that's a very good point. Because sometimes I do see that when parents, they strive to meet the development milestone to be as close as possible, but we tend to overlook on the child well-being in terms of mental health. We send them to multiple therapies, tuitions, and whatnot, but we forgot about it's still a child. 9 years old, it's still a children. Like even us as an adult, when we work 7 days, we do feel tired as well. Yeah. So, and then what I can add on from other parents' feedback to this is the improvement on play is very little, but it's still an improvement. Okay. And then also, I would suggest you to talk to the teachers, because like what doctors say, if the gap is too big in terms of academic, I would suggest the parents to look for alternatives, because let's say the child is now 9 years old, but unable to recognize, this is just an example, I'm not saying this child has this difficulty. So let's say this child is 9 years old, but unable to recognize ABC, then obviously the gap of academic learning is quite huge. 9 years old, you have to roll all the way back 5 years. It's like 3, 4 years old, it's almost close to 6 years. So that's where parents, you have to see whether it's realistically achievable, because 6 years of gap is, I don't think it's easy to achieve. You might want to explore alternatives, because like what doctors share also, when play, they interact with others. It looks simple, but actually it's a complex process. They have to learn how to share toys with others. They have to request, they have to express, and this and that. So, yeah, thank you for asking this question. But this is what we can suggest based on the limited information about the child.
Yeah, Mr. Wong, may I just add one thing?
Yes, sure.
So the other thing I feel is important is we have to remember that even though we measure skills objectively, and like say 6 monthly, we'll say, okay, this is what your child, this is how much he or she has improved. When say somebody acquires skills, it's cumulative in a way, and at the end of the day, there's a spillover. So if like say certain skills improve, you'll find that you may not see it immediately, but later on you may improve other skills as well. So sometimes you may not see it straight away, but over time you'll find that if the child is improving in, say, maybe play-based setups or in setups which are slightly less academic, you might still find that the academics can improve also, because confidence is a big factor. And often that's overlooked for children who are not typically developing, but just because they're not typically developing doesn't mean that they don't have feelings in that sense, and that they don't have to
Yeah.
have confidence and
Yeah.
and self-esteem. And because often everybody says like, oh, can't do this, can't, so language, I think, is important. We have to not phrase it negatively, which is what I just did actually. We need to say that these are the things that are good, these are the things that can benefit from further improvement, and a lot of that helps. It really does. And when they're more confident, they're more willing to try new things, and then you'll find that at that point maybe they'll be more ready for the academics as well.
Yeah, I do agree with that. If you see it from an adult point of view, when you work and your boss asks you to do something that you don't like, definitely you couldn't perform well as compared to you enjoy doing what you like. So it's almost exactly the same when you put in a situation that you don't enjoy. Definitely it will affect self-confidence because you're not very good at it or you don't like it. So this is what we're trying to share with parents and teachers out there. Sometimes by forcing it blindly, you achieve something that I think is short term. It's not going to be long term in terms of motivation. It's heavily rewarded externally. Like you do this, I give you, whatever you want, but it doesn't instill the internal motivation. So once the external motivation or the reward stop, then you don't see this performance for long.
Yeah.
So yeah. So next question, also related to school. I think my child used to enjoy daycare and preschool, 2 years old. So now after the MCO is 4 years old, he was toilet trained, but now he will cry before going to school, avoid teachers, avoid classmates, and then even wet himself in the school. Like he did not tell the teacher if he want to go toilet or not. And sometimes he just speak 1 or 2 words in the school. Sometimes he just go quiet for the whole time he's at school. Yeah. So currently, what can the parents do?
Okay. I think it's a very good question because even in the clinic, I'm seeing more kids who are presenting with this sort of anxiety in a social setting. I don't quite want to label it as social anxiety because I think there are lots of other aspects as well. But particularly for this group of children, like, who've been half their lives in this COVID environment, they haven't really had the opportunity to explore and to gain confidence with interacting with other people. So when you're in a very controlled environment for a very long period, and then you're suddenly said, okay, let loose and say, okay, people say now you need to do this and that, it can cause a lot of anxiety. It's like how children sometimes present when they suddenly go to primary school after they've been in the more protected kindergarten environment. So this one, he's probably been home and then now suddenly goes out, and regression of skills due to stress, due to anxiety, due to a changed environment can happen in toddlers, and it can happen in even school-going children. But I think the regression of toilet training is related to that, and also the anxiety being around other people. Also, it's important to just be mindful about what it is that's being discussed at home. So I mean, I'm not presuming to say what's happening in this situation, but I think I'll just talk in general context that if everyone is anxious about a lot of things, and I think many adults are anxious about a lot of things now. So if that kind of anxiety is present all the time, children often pick up on that, and then they gradually become more anxious about these things also. So that can affect their confidence. It can cause a lot of separation anxiety, and that can also result in these sorts of toileting issues and behavioral difficulties. So it's very important to maybe ease the child into the routine instead of saying go for 5 days a week suddenly. It doesn't have to be all or none. You can maybe negotiate with the daycare or the kindergarten and say, can you bring him in a little bit later in the morning so he doesn't have to go through that initial rush to get in, and then he comes back a bit earlier or at the end of the day. Or you can say, go in the morning if that's easier for you for your work, but then maybe have him come back a bit earlier. The other thing is maybe negotiate certain days, like say maybe 2 days a week, 3 days a week. Then once he makes friends, he feels more confident, he feels more, happy in that environment, then you can gradually ease him to 4 days or 5 days. So a lot of that can be negotiated with the kindergarten. And the few lost days of school at the end don't really matter that much. It's more that, it doesn't set him back so far. If he's reluctant to go, even if you sign up for 5 days a week and he's reluctant to go for 3 months, you're probably cumulatively losing more than you would if you had it on staggered days from the beginning. I think those strategies help. Also, it would be good to speak to the teachers and ask them what it is they've observed. Do they notice whether there are any particular triggers? Because for, typically developing or neurotypical children, certain things can cause issues, but also for children who have autism or have, developmental disabilities, sometimes some sensory things can come in. It could be the environment. It could be that there are so many people there, that it's noisy, that he's being rushed, that he may not like the colors of certain things or the textures or smells. It can be a lot of all those things. And the teachers will often be able to give you that information, which will mean that you have more essentially more information to decide and to figure out what it is that's causing difficulties. Also, preparation, mentally preparing him before and being calm about it as well. If parents are anxious about that separation themselves, the child might pick up on that. And I think it's probably, natural for the parents to also be anxious about letting their children go into these environments when they've been protected at home all the time. But children often are very intuitive and they pick up on these things. They may not be able to express it or articulate it, but it sometimes shows up in these ways. And maybe telling him like, okay, tomorrow we're going to do this, get him to prepare. So you can maybe prepare his little school bag or prepare stuff, have a routine, which can also reduce anxiety. So some predictability and control is important for children to feel that they can control the environment a little bit, but too much, of course, is also not good. But this way, there's a little bit of anticipation of what's going to happen.
Yeah.
Yeah.
So, I do appreciate parents asking questions like this because, when we talk about developmental issue, it doesn't necessarily mean that it has to be, the child has to have certain disability in order to have this. This is one thing that we see quite often nowadays because the children are not exposed during MCO. A lot of things that it's very different before MCO. So these are the things that parents have to be aware or vigilant about, because it's good that you notice now and you can ask questions, and then we can share our knowledge on what about to do. Because and some parents, I would suggest, don't straight jump to diagnosis. Nowadays internets are very powerful. You just type in anything and then you self-diagnose. Okay, so self-diagnosis is very dangerous in a way that parents, when they tend to believe on something, but the child is not, then they will see the child as how they see fit, but actually it's not. So it's good that you ask questions and start looking information, and like what Dr. Shubha has suggested, maybe you can start working on it, and also collecting information, because it's okay for you to feel not comfortable with how your child behaves, because there's a lot of things happen in the past 2 years, so which we are not in control with, and then like what Dr. Shubha shared in the slide before, each age they have their own development stage. So if something is missing or lack of exposure, that's where the red flags come in. So it's good that you understand how your child behaves before and after MCO, and that's when you seek for information, speak to the doctors, and you can find out more. Okay, so talk about anxiety. We have a question about anxiety. My child is diagnosed with selective mutism and social anxiety. Do I need to see a developmental pediatrician?
Okay, so I think it depends who you've seen for the diagnosis. Like if you've already seen someone and it's, that diagnosis has been made, and you have therapy ongoing, you're working on those strategies, you may not need to see a developmental pediatrician. we would like to see everybody, but I can tell you in reality, I know that it's just impossible. So if your child is sort of being looked after, and maybe you've seen a child psychiatrist who's made the diagnosis, or a child psychologist who's done the diagnosis, then I think that's okay. But the 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 important thing I feel is that you need to also see whether this social anxiety and the selective mutism are part of something else. So just have to stand back and see, is it part of a bigger diagnosis? And are they just, sort of symptoms of that? Or are they there in isolation? I mean, I'm not trying to alarm anybody, but often we see selective mutism and social anxiety with children with high functioning autism or mild autism, and particularly in girls. So in certain environments, they decide they're not comfortable, they don't talk. In some environments, they feel more comfortable, they talk. So that is something to think about. But if whoever has assessed your child has already looked into all of that, then I think that's okay. But if not, then it may be good just to get a one-off assessment, and then you can follow up with your regular healthcare professional. But you don't have to, there are many avenues for assessments. It's just that we want someone to look at the big picture. That's all.
Yeah, also to add on, you can speak to the person or the healthcare professional that provides this diagnosis.
Yes.
And then I believe they will guide you.
Yeah, that's a very good point. Yes. Yeah.
Because from here we wouldn't know.
Yeah, it's very hard to. At the same time, if second opinions and all that are fine. Everybody understands that that's something parents need to do sometimes, and that's okay. But it's also good to be upfront with the healthcare professional you've seen to say that I'm looking for another, rather than shopping around. I think if you look at it, doctor shopping can be a problem for two reasons. One, for the family, when you go around everywhere and you're on this long diagnostic odyssey, you don't quite get a final, you don't come to resolution, it can be hard to move forward. The other thing is also because we know that there are not so many people who do these assessments. If the same families go around to many people, those spots are being deprived to other people who may want a first assessment. So I'm not trying to say that that's the situation here. It's just that sometimes when these questions come out, it makes me think of related things. So I think that's important. But speak to the person who made the diagnosis and ask them. It's possible they may be able to do the further assessments there as well.
So, Doctor, you talked about gender just now. There's a question about it.
Okay.
Is it true that boys has a higher tendency to get autism as compared to girls?
Okay, so if you look at the statistics, generally speaking, it differs depending on where you look it up. But overall, you say 1 girl to every 4 boys. But why that is interesting, because it could be that really boys tend to present more with autism compared to girls. But I think the more relevant question is, are girls underdiagnosed? Because often girls present with symptoms which we don't automatically associate with typical symptoms of autism. And that seems to be more of the trend now. So there may be many girls, I'm not sure whether, it's hard to say whether it'll be equal number, but there'll be many more girls who are undiagnosed, because when, we think of ASD, there are lots of typical features that we look at, and girls do not always have those features. So unless they extend that, like say when they do the diagnostic criteria, we start incorporating a lot of other features, you may not pick up on that.
Thank you. Because sometimes parents ask me this question, I have no idea. Because even some parents who are interested in research article, I always recommend the research has been taken up in Malaysia settings, because a lot of research done in the Western countries, but they don't represent the population as a whole, because in Malaysia we have really a lot different culture. So it only apply to certain, but we just take it as a general guideline. But if possible, those parents who are interested in reading articles or researches, please do search like UM, UKM. They have tons of researchers which is Malaysia based.
So, and then they can be as specific as certain race only. So that's where, you can learn from this because it does represent the Malaysian population. So sometimes I know parents will start questioning why the Western country doing something that we are not, like in terms of therapy or diagnosis. So generally speaking, because of uh, differences in the population, it makes us slightly difficult than the Western country because we have a lot of things to consider, individual differences, cultural, race, a lot. So not everything that is done in the Western country is applicable in Malaysia.
And I think like what you mentioned, Mr. Wallace, is a very good point that if you look at like the cross-cultural and international kind of perspectives, it's very, very different. And sometimes not all countries, of course, but it can also happen that in certain, if you say Western countries, they may not take into consideration the minority group. So it's not that they're not there, it's just that it's predominantly one particular culture. So that whereas here we're fortunate in that sense that because there are different cultures, we may be a bit more aware and open to those things. But when you look not just here, in some places elsewhere also, there's increasingly an acknowledgement that many children don't present and don't get diagnosed with ASD if they come from minority groups or they come from groups which are underrepresented, because often the people who see them and diagnose them tend to diagnose developmental delay instead of autism. So that's interesting because depending on cultures, even things like eye contact, in some cultures, children are not encouraged to have eye contact because it's supposed to be it's confrontational, right? So those sorts of things can be very different. So we have to be aware of those things as well.
Correct. Okay, and also there's a question about, okay, I'm still waiting for my appointment to see a developmental pediatrician, but can I know what is global development delay?
Okay, so global developmental delay is when there's delay in more than one domain of development. And that's just a definition. It's not a final diagnosis, but it helps us understand what the deficits and strengths are. Like I think one of the earlier slides that I put gross motor skills, fine motor skills or skilled hand movements, then language, speech and language, as well as social skills, and then overall in terms of cognitive. So there are basically like 5 broad domains. If your child has difficulties in more than one of those domains, we would call it global developmental delay. If it's only in one domain, then we will say that it's delay in whichever specific domain. It's a term that's descriptive to explain that, but we really still need to look at what are the underlying reasons for that developmental delay. The other term that's sometimes used is early developmental impairment, and it can be used interchangeably with global developmental delay depending on what you read up. But for both, it's until age 5. So once a child is more than 5 years, we don't call it GDD or global developmental delay or early developmental impairment anymore. Then we need to look to see whether whether the development is typically developing now, has the child caught up, or whether the delays are still there. The other thing we need to look at is whether there are issues with learning. So is it a learning disorder that initially presented with global developmental delay, or could it be some other diagnosis like autism or any other diagnosis that presents with that? So sometimes even children with particular syndromes, particular medical conditions can present with global developmental delay. The other possibility is whether there are issues like, say, intellectual disability and those sorts of presentations, which also can present with global developmental delay. But I think while you're waiting to see someone, it's again going back to the initial model. We always want to identify strengths and difficulties, and those therapy for that can go on regardless of the diagnosis, because your child is not the diagnosis. The child is so much more than that. The reason for diagnostic labels is it gives us a way of maybe communicating it to other people rather than giving a 10-page letter with all these things. So that's why we use diagnosis. And particularly for communicating with schools, with other therapists, with allied health, with other doctors, it's important. but it's much more important to make sure that your child is getting the help and support that he or she needs.
So for example, diagnosis we see like autism, they put dash speech delay. So meaning
Ah.
that this child has been diagnosed with autism, specifically the area is speech area.
Oh, okay. So it could mean that the person referring says that the child has autism or maybe has speech delay. That's the kind of
Ah,
referrals we get sometimes.
uh-huh.
Or what they mean is that autism but presented with speech delay. I think
Ah.
that's usually what they mean.
So that's very good for to clarify, because sometimes parents, after they see the area, then they were thinking why the doctor only put
Ah,
speech. Now I understand. So it can be for the purpose of referral, let's say to a speech therapist. So that's why the doctor put that. Like,
yeah.
okay, all right. So parents, like what Dr. Subhai said, so it's for communication based. Sometimes, yeah, we understand that you are quite concerned, and then it can be confused. Like I myself, like presented some of the area, but it was different. So it can be
Mm.
for referral purposes, or maybe like what doctor has shared that presented, maybe that area is the delay is bigger or greater than any other area affected. Okay, okay, I have to limit the question. I think probably I have to, yeah, I have to put it the last three questions. I'll pick up the shorter one because we are already towards the end of, almost towards the end. Okay, so the next one is, how do I know which area of development to focus on first if my this child is with autism?
Okay. Also, it's important to remember that a child with autism is a child with autism. Not every child with autism will have the same things, same deficits, just like with any other diagnosis or any other condition. So it has to be individualized for your child. Maybe speak to the doctor and ask the doctor which are the areas that he or she feel you need to target more, which are the areas that your child already has strengths in. And of course it's important also when there's strengths that we don't say, oh, he's good at this, and then we ignore it entirely. You need to make sure you keep building on those areas, but you may need to maybe intensify and focus on the areas that he needs a bit more help with. And these things are dynamic, so at this point these may be the pattern or the profile of strengths and difficulties, but in another few months it may change a little bit. So we need to be able to be flexible with changing our focus as well.
Yeah. So like what if you have joined the talk early on, you can hear that Dr. did share uh, about therapy, where if you do a lot, or you apply for, or you send your child for a lot of therapies, that doesn't mean it's good for the child. It's just that you have to understand your child and pick the right therapy for your child to address the current issue. Because if not, you'll be like randomly picking anything. Hopefully, it just fix some of it. Okay. All right. The next question is, my child has language difficulty, uh, and we speak different kind of languages at home with the carers as well as the school. So which language should I focus on? The language that they speak in the school or at home?
Okay, thanks for that question. It's, I think, very relevant to many families. I mentioned it very briefly earlier, but I think there are a few things. Again, one is maybe look at which language your child is most comfortable with. So whichever language he or she is most comfortable with would, generally speaking, be the language that you want to focus on. Secondly, if depending on what language medium instruction is used at school, you may need to add on or modify accordingly. But I still feel that you should go with which language your child is most comfortable with, and then the school should fit into that rather than the other way around. Rather than saying, I want to send the child to this school, so he or she must learn this language, it's probably better to work the other way around. You can still learn additional languages, but learning extra languages just to learn the language is different from having to learn languages which you need to know well enough in order to learn other subjects. So if the medium of instruction is whichever language and the child is struggling with that language, then sometimes he or she will miss out on learning the academics in other aspects simply because they cannot acquire those skills because of the language difficulty. So you don't want to add on the challenges there. Uh, Also, depending on how old the child is, if he or she is already in a school and already in a stable setup there, then you may need to say, okay, now we're already going to, he's learning this language, then we need to improve his skills in this language. But if he's still comfortable with another language as his mother tongue or as his, whichever language he's most conversant in, then I will work on that as well. So there are many situations where, unfortunately, in some ways, you can't just pick one language and do everything in that language, because there will be a lot of times where the child needs to have skills in other languages. But it's also a good thing, because there's also a lot of evidence that having more than one language can be good for learning. But that doesn't mean that you should teach your child 5 languages, or it just means that sometimes that having that little bit of extra is good, particularly when you live in say here in Malaysia. You can't really survive with just one language, whichever language it is. You need to have more than one, and for practical reasons, it's very important. But also look at which language you're most comfortable with, and then that's the consistent input that your child is going to be getting. So that's also very important. So I know I haven't given you a straight answer, but I think there's no yes or no for this. You really have to see what the situation is.
Yeah. And then the parents of this question, that posed this question, also ask, can the delay in development be on par, or forever there will be a delay?
Oh, okay. So that's a very good question. I think it also depends on the child and depends on what the delays are and how much the delays are there. The degree of delay. Often, if the delays are not mild, if they're moderate or severe, very often we find that the developmental trajectory is such that the gap widens as the child grows a bit older, simply because the expected performance at different ages goes up in complexity. So you'll find that it does tend to widen. The idea is we want to narrow that gap as much as possible. If we're lucky and if the child has unique strengths and they're able to narrow that gap, sometimes some kids do have like optimal outcomes where they do tend to go back into the normal developmental range, but it doesn't always happen. So it's important for families to know from the beginning that the idea is we want the child to achieve his or her full potential, and we want to optimize that as much as possible, but we are not comparing that child with everybody else. We need to compare that child with himself or herself. So imagine your child 6 months ago and now, and we're hoping that now you see improvements. And then 6 months from now and now, there should be differences again. So that's the aim, rather than trying to get the child back into the typical developmental range. If that happens, it's great. If it doesn't, it's okay, because the idea will be just to make sure that he or she fulfills their potential.
Yeah. What I can add on is some parents, for me, I share with them, it's like it's a marathon, it's not a sprint.
Oh, yeah.
What we want is, it can be long term. Sometimes it can be on par. Sometimes regress, we never know. But the most important thing is the child able to continue learning if they are in an academic setting, and it's not disrupting their daily functioning. Like it's not stopping what they are doing, or it's not stopping their obligation. Let's say going to school and whatnot. But that's all I can suggest, because we really don't know how it will turn out to be. But what I can say is, in a general way, it's like when when you have when you're not feeling well, you go and see a doctor. The doctor prescribe you with antibiotic. Most of the time, people will stop eating. They will not finish because they feel like, I'm already good. And why do I need to finish the antibiotic? So same goes to therapy. When you see the child is no longer, like you see your child have a very big improvement, you can talk to the therapist instead of stop prematurely and then not going to it anymore. Okay, because this is very important, because then you're able to work with the therapist. Maybe you can reduce the time to see them instead of once a week, you can reduce to once a month, because I've seen this a lot where suddenly parents stop abruptly because they are happy with the progress. And then down the road, 3, 4 months, 6 months, they come back. Hey, what happened? My child, go back to when I first see you. So this is something that we don't want. So say,
Yeah.
oh, I'm not a doctor, but I pick something that everyone can relate, which is antibiotic. I myself sometimes I'm very confident. I stop myself, but then it's not very good. So everything talk to the therapies. Yes, I understand parents are concerned about the development, but we don't have a direct answer for that. But the most important thing is discuss with your therapist or doctor. Okay, I have one last more question, and then the rest, if you have any more, you can put it in the comment. This video is recorded. It's available on our page. So if anything, you can just comment even though the live ended, and I will try to reply as many as possible. Okay, and one last question. Okay, my child is 30 years old. Used to see developmental pediatrician in hospital, government hospital. And then now he has to see a psychiatrist. So the parents want to know what is the difference between psychiatrist and developmental pediatrician.
Okay. I think there are two parts to that question, right? So firstly is, why is the child seeing a psychiatrist now? I think that varies from hospital to hospital, and there are lots of factors. If, in terms of numbers and, what their capacity is to see children, sometimes they have to transition to a child psychiatrist to take over, a child adolescent psychiatrist, so that they can take over during the teenage years, and then later on they will transition to an adult psychiatrist. Mainly for children who need medication, or children who have behavioral difficulties, like say for autism. Sometimes, unfortunately, there aren't organized transition services, and that's a big gap. And we have that same problem. So a lot of times we hold on to these kids till they're adults, simply because we don't know, we don't have anyone we can send them to. And that's also not ideal, because when you're a bigger kid and you come to a pediatric clinic, it's not really fun for that child, right? They look much bigger than all these small kids, and then they feel like, why am I here? So sometimes they end up not wanting to come or disengaging, and that's not good. But until and unless transition care is addressed, this is going to be a gap. So sometimes it's possible the doctors had to do that for that reason. The other thing is, of course, when you look at say developmental pediatrics and child psychiatry, they some of the things overlap. We just look at it from a different lens, but we are still able to do different things to help. So for developmental pediatrics, our main hat is as pediatrician. So as you would see a physician, like say if you're unwell, an adult will see a physician, and then they might go and see the chest physician, or they may see the rheumatologist, or they may see someone subspecialized. In our case also, but those people are still physicians at the end of the day. So for us, even though we're developmental pediatricians, we are still seeing from a pediatric point of view. So most pediatricians would still have a developmental perspective, in terms of, even if they're not developmental pediatricians. And we do what we're talking about: identify strengths, identify difficulties, try to help the family and support them along the way, and see how the child is progressing. And then try to address the families and the children's needs. For psychiatry, they also do family-based, but they look from a psychiatric point of view. So they're psychiatrists, and then they sometimes see children, or they are adolescent psychiatrists, which is more subspecialized in terms of child and adolescent psychiatry. They can also diagnose just like us. So in terms of diagnosis, that would be the same. But in terms of longer term management, sometimes they transition for a bit longer, so they can see the older kids. Also, if they're giving medication, things like risperidone, those sorts of things to manage behavior, they usually can see the children more frequently to titrate and to adjust those things. And they often have more clinical experience with those sorts of medication, because they use it much more. Whereas for us, we use it, but we only use it in certain situations when we need to, and often we don't have the capacity to see the child as frequently. So for the ones who need very frequent fine-tuning of medication in terms of behavior, sometimes it's better for the psychiatrist to see. There are times where we see at the same time. So I mean, maybe not the same sitting, which ideally we should, but due to logistic reasons, we usually will co-manage. For like say children with ADHD who need those sorts of medication, often we can see as well, just like the psychiatrist. It's more for the antipsychotics that they tend to manage that more.
Yeah. So more on specialized medication
Yes.
that
Yeah.
is under the area of psychiatric,
Yeah.
which
And yeah,
the mental pediatrician don't prescribe.
Yes. And also, I think working with parents, like psychotherapy with families, those sorts of things, that's because it's therapy for the adults who are part of the family, that will be beyond what we offer.
Yeah. And also, if I'm not mistaken, it's part of the government hospital policy. Once your child is above 12, it's no longer under pediatric department. It has to be transferred out. So,
Yeah, I think I can't speak for the MOH hospitals because I think it's slightly different. And if I'm not mistaken, it's different in different hospitals. So there'll be slight variation in policy. But like for university hospitals, we also have that, but there's a little bit of leeway, as in if they're under follow-up, we can continue longer. So, it depends on hospitals as well.
Yeah. So parents, you can, there's no harm asking, because this is what I have feedback from other parents as well, and also a child and adolescent psychiatrist. Last year, if I'm not mistaken, I have this talk with a child and adolescent. In the government hospital, they do have policy like this. So when they strike on his birthday, strike 12, 13, then they have the next appointment, you are unable to see a pediatrician because that's just the policy. It's the care has to be taken by different departments. So the closest to a developmental pediatrician is a mental health professional like a child and adolescent psychiatrist. But like what doctor have shared, just to share with parents, they are all doctors. I know the stigma when you hear a psychiatrist is very strong, but the most important thing is they are doctors, they are there to help you. It's just that they have different area of specialization. This doctor, they have interest in psychiatric. Dr. Shubha have special interest in development and pediatrician. So they are still doctors. They are there to help. And like what Dr. Shubha have shared, we have limited transition and also have professional in this area. So that's the choice that we have. But by saying that, that doesn't mean they will be doing things that totally different. Okay. Yeah. So please do talk to the person in charge, and then to find out more. Like what doctor said is different. Okay, so we're already at the end of our talk. Thank you so much, Dr. Shubha, for joining us today.
Pleasure.
Okay, and then for those who are interested to find out more, Dr. Shubha is from UMSC or also University Malaya Specialist Center, and also she is a doctor for PPUM, which is the government side of Hospital. So for those who don't know, even I myself only recently, like 2-3 years ago, then I found out that, oh, actually UMSC is different from PPUM or UMMC. UMMC is the government. Am I correct, doctor?
Yes, yeah.
Exactly. UMMC, University Malaya Medical Center, is government, and UMSC is the private part, but they are still all under UM. Yeah, I only recently found out as well. So for those who are interested to look for a developmental pediatrician like Dr. Shubha, you can make an appointment with her at UMSC. So like I said, due to the lack of number of developmental pediatricians, the queue, I cannot confirm when, even doctor herself cannot confirm when, because it's very limited. There's about 11, right, doctor? 11 or 12?
Yeah, I think they're 12 now. Yeah. But you don't have to see me. I mean, you can see any of the developmental pediatricians.
Yeah,
so,
available. Yeah. So this is Dr. Shubha is one of, I think in Klang Valley, there's about 5 or 6 of them. The rest is outside each different state. So, so this is something that I want parents to be patient, and then there's only one, like UMSC, there's only one, which is Dr. Shubha. So the queue is definitely going to be a queue, and just be patient when you schedule an appointment. Yeah.
But I think for the patients who are okay to come to UMMC, which is our government side, we have clinics there as well. So that's not just, I mean, I'm there, but it's also run by our team there. So of course, the wait lists are the same. It's just that it's an option if you want the government side or the university side, the public side, essentially.
Yeah, yeah. So for parents, if you like, this is what I always tell parents: government hospital or public hospital or private hospital, you are looking at the same area of doctor. It's just that price difference or maybe convenient, because there's more for government hospital, there's more procedure to make an appointment. For private, you can just call up, hey, I would like to make an appointment. But for government hospital, there's a process. Like clinic kesihatan, refer to hospital, and then to, or maybe direct straight. You have to have referral letter to get into a public or government hospital. But that doesn't mean parents has no choice. So and like I always tell parents, just spend within your limit to not overstretch your financial, because it will create a burden to you. Like what we always share, if your child or any child with special needs or disability, it's a long run, it's a long term thing. It's nothing we can do to shortcut or make it better, and there is no cure. All right. So there's a lot of myth outside saying, you can cure autism and whatnot. But no, apparently, evidently, there's no such thing as cure for autism. What you can do is, like what Dr. have shared, strategies to cope on their well-being. Okay. All right. So thank you, everyone. Yes. Okay.
Oh no, sorry. Just to add, if it's okay, it's just that I think we need to remember these are developmental differences. They're not diseases, so we're not looking for a cure. They're just conditions. So I think at the end of the day, we just want to optimize things for all these kids. And also, like, working on self-care is very, very important for independent living later on. And that's sometimes not focused on, but we really need to do that for the child's sake. Also with communication, even if they have difficulty with verbal communication, we still need to work on non-verbal communication, because things like tantrums get better when the child can communicate. So just
yeah, and then and then also one of the take-home note that I get from Dr. Shubha's sharing is, when you see a doctor, it doesn't necessarily that you have to have diagnosis in order to know what to do next. Okay, so this is something that I learned, and it is very good to know, because nowadays after MCO, even some of the questions from the parents, like, the child doesn't have any diagnosis or doesn't present any sign or characteristic of disability, but they do have they presented some characteristic like anxiety and whatnot. So that doesn't mean your child is disabled or have disability. It's just that they are experiencing some difficulty, which related to the developmental stages, which Dr. has shared. So I hope all the parents are able to gain information from Dr. Shubha. If those who missed out the fun part, this video is recorded. It will be available on our page, and then anytime, whenever you're free, you can go back and look at the slide that Dr. Shubha has shared. All right, thank you so much, everyone, for joining us today, and thank you, Dr. Shubha, for sharing information about developmental and also your role as a developmental pediatrician. Yeah, thank you so much, and hopefully we'll in the future we will have another talk like this. All right. Okay. Thank you.
All right. Thank you.
Bye-bye.
Bye.